All right, good morning out there in cyber world today. We have a great guest for our show. I think this is our fourth show now, called Dental Raves and Occasional Rants, with the concept of talking about some current topics in dentistry, but just as much fun to interview different people around the world, some personalities in dentistry, both clinicians and researchers, and also dental technologists to get a perspective on what's going on in the world today, dentally, and maybe a little bit of just what's going on in the world today, from where somebody's situated today. So we're so fortunate today to have somebody that's become a very good professional friend of mine. We're in a couple of groups together. Alessandro Devigus. Many of you probably already know him. Probably doesn't need introduction, but I'll go ahead and do it. He's been a professor at University of Zurich. He practices in Zurich, obviously, a high-end restorative, minimally invasive practice. And I've had a chance to learn a few things from him over the years. He's developed a passion for photography, not just in dentistry, but in general photography, portrait, landscape, still photography, desktop photography, macro photography, really every form of photography. And he's evolved that into really an amazing platform called Dental TV. And so we'll link in the show notes, and he can show us a little bit of it or talk about a little bit of it today. All the teaching he does, not just in photography, but it started out really in photography, educating people really on camera systems. He tests literally every new camera system that comes out. So he is probably, in fact, there's not even probably, he is the best resource in dentistry today for our particular needs for our intraoral imaging. He's evolved that even beyond that to talk about how all of our imagery relates to social media, marketing, how to use social media. He tests lots of programs related to that, both that work on phones and also on your computer systems. So, Alessandro, why don't you say hello to the audience here, and then we'll get into it.
Wow, thank you for this amazing introduction. So I'm always like speechless, but no, it's a great pleasure, great honor speaking to you from one side of the ocean to the other side of the ocean, with a country in between or a continent in between. So you're getting up. I'm not about to sleep, but I just finished my work with my patients today, and I'm really happy to share some insights and some information from my passion. So beside being a dentist, a passionate dentist, you're right, I'm a passionate photographer, because one is the passion for photography, and the other thing is my passion for clinical documentation. So we have to be aware and to know that dental photography is like X-ray. So we have like two tools besides scanning. Let's say scanning is the third one, but we have three visual options to check our patients. So we look through our patients with X-rays, standard X-ray, 3D X-rays, whatever, and we look at our patients with photo, video, scanners, face scanners, whatever. Sure. And what I see over the last years is that there's a distortion in this clinical documentation that's going on. So I made like a provocative post a few months ago.
How do you mean distortion? I mean, so do you mean people manipulating the images is what I'm guessing?
Distortion in the sense not recording the pure information.
Right.
Getting a diffused image, getting a softened image.
Okay.
I was like talking about, would you put a softbox on your X-ray machine?
No. And I've never really liked softboxes. I can just tell you quickly what I would do, and then you can get into what you would do. To me, many of you probably know I do my own ceramics. I know you do, Alessandro, and it's very important to me, especially if I'm doing a single central or two centrals, to copy the surface reflection that I see on a tooth, okay? And that requires surface texture and polish to be correct, and the surface has differential polish. So if I don't see the surface correctly, I can't do that. And when you diffuse light, it changes surface reflection. It might be an aesthetic look, but then it becomes very difficult for someone to copy that then. I have to do that with my hands, essentially. And if I don't have an accurate image, like you say, an undistorted image, that's not possible to do. And so that has been been one of my things that I have not liked to see either, to tell you the truth.
And what amazes me is that if you're talking to professors from university, even the teachers are now telling me, oh, we take all our clinical images with diffusers and softboxes.
Yeah.
So my question related to this is, why should we spend hours on textures, be it in ceramic, in composite, or whatever, if then we cannot show the result, or we cannot share the result because with the diffuser it's all gone. So everything looks nice. I know this was a trend that was initiated several years ago by Inaki Gamborena and others. And the reason was, let's say, the diffused image, the softbox image was done especially by lab technicians to showcase their work. Let's say you have a crown on a white plaster, and there's too much reflections, and so they try to reduce the reflections to see the beauty of their work. But they try to really do it in a soft way and combining images. And this trend then jumped over to the dentistry and say, it's easy. How can you make your work look great? Just use a diffuser or a softbox and everything looks nice because you don't see the result anymore. So this is, when I was editor-in-chief of the International Journal of Aesthetic Dentistry, I always thought,
forgot about that too. Yeah.
No problem. But I don't have a problem if you send me diffused images because you like them better, or social media likes better this soft touch, this Hamilton style. You maybe remember the Hamilton, this blurry photographs of young girls where you didn't see all the details. If you like it, okay, but give me also the real picture with all the reflections that might not look good, but shows me what you have done. So you always should record both images. You can do is say, okay, I have a case where the reflections are too much. Let's put all the diffusers and take an additional image to maybe see more details, but not do one. And you know what I mean?
Yeah.
For me, it's a combination. It's a new way of taking pictures, but only in addition.
Yeah, and to other things that are, I think, contributory as much or more, is one of the things you start to learn when people do that is that hides mistakes, okay? And it sort of blends everything, so it does look good on social media, or maybe it does so-called look good in an article. The problem becomes in real life, right? Our patients don't exist on our screens, on our computers, or on our screens, LCD screens, or LED screens when we're lecturing. Okay, they exist in conversational distance with people, and this is where it loses something. Okay, now again, if you're doing 10 or 12 teeth, maybe not such a big deal. Okay, but if you're doing 1, 2, or 3 teeth, which we still do on patients, they don't always all want all of their veneers done. This is where it becomes a gigantic problem. And you know, my practice kind of is a little bit heavy in that over the years, that I got more single centrals probably than the average person because of that. It just doesn't look right, Doc. Well, it didn't look right. 1, they didn't match the color. 2, they didn't match the shape. And 3, they didn't match the surface reflection. And you're right. If you don't have the right image, then you can't copy something. So we'll spend a little bit more time in photography in just a little bit, but I wanted to get a little bit more sense about you and about Zurich today and what's going on in Europe to start with the audience. So how did you get interested in dentistry? Did you have family members in it, or was just the type of kid that liked to fix little things and make model work and things like that?
I always wanted to become a journalist. And then when I was 18, so that's why I ended up also as editor-in-chief of the International Journal of Aesthetic Dentistry, so I could live one of my dreams that I had when I was younger. But at 8, when I had to make a decision, so I realized that becoming a good journalist, I had to go to Germany to study, because at that time when I was young, there was no university teaching professional, high quality.
Still a young
journalism.
man.
Yeah, okay. But and then two people from our class. So a boy and a girl from my class. They told me, well, the girl decided to study dentistry because her father was already a professor, a dental professor. And my friend, the best classmate, told me, I want to become a dentist and make money.
Okay.
And then I told, okay, he's a good buddy. Okay, dentistry is not so bad.
Yeah.
I also like to work with my hand. So I was like, becoming a doctor was an option for sure. And then we started studying dentistry. And now of the three, I'm the only dentist, you know.
Okay, great.
And I finished my dental school. And during dental school, I had like my major episode that really had the biggest impact on my dental career. It was a lecture when I was a young student from Professor Merman. In 1985, in 1985, he presented to us the CEREC system.
Yeah.
It was like standing in front of us and telling us, imagine a machine, your patient, yourself, and all these three elements are working on the patient and creating something.
Yeah.
And the term chairside dentistry was born in the sense of, we all do chairside dentistry when we do a filling, but the chairside dentistry assisted by a computer was born in 1985.
Right.
And then in 1986, I received 5 inlays, small inlays, done with the prototype of the CEREC machine, and they are still in my mouth.
Well, you were at the very beginning.
So the virus took me over, and from that day, for me, it was clear whenever I open my own dental office, I will start doing CEREC restorations. And so I did.
Yeah.
I started in 1919. I bought 2 CEREC 1 machines because everybody was asking, why are you buying 2 machines? And I said, look, if you're a professional car driver, if one car breaks, you need a second one because you don't know. So for me, it was like the safety backup. And I always had then 2 CEREC 2, 2 CEREC 3, 2 CEREC Black. So I ended up buying now, I think I bought 14 CEREC systems so far.
Wow.
I did 35,000 restorations. And I still love it. I still love it because the thing is, if you invest into technology, there's one thing. Technology can make you better, be it CAD/CAM, be it a microscope, be it whatever technology you're using, but you also have to become better.
Right.
I always make the comparison. The Formula 1 car is the best car in the world. But we cannot drive it. We are not able to drive it. If we sit in that car,
we die.
In the first curve, boom, out, you know, or even we cannot start the engine. So we are really messed up totally with this too advanced technology in our hands. And this is also something that I sometimes feel. Why are dentists not using more technology in their dental office?
Right.
And I think beside the investment, one thing is also the fear of not being able to control the technology.
Right.
So
for sure.
missing out, what are the benefits? What can this technology help me with? Can I become better? Yes, but only if you improve yourself at the same time. So if you buy a microscope, you have to change the way you work to make the best out of using it. If you buy a CAD/CAM system, you have to train yourself, you have to adapt a lot of techniques, workflows in your dental office to make the best out of it and to become a master in using this technology. And so many people then say, or many dentists say, oh, I will take my poly impressions and my alginates and do this and do the old school thing because I learned that at dental school and this works.
Right. Yeah, to unpack a couple of those things, great. And so everybody out there, that doesn't know this, maybe the younger dentists, CEREC actually started at a brainchild of Professor Mormon at the University of Zurich. So it unrolled out of there in the idea in the early 1980s and hit the market maybe mid-1980s. And sound like you're one of the early adopters. And you make an outstanding point about technology that people don't understand, but specifically related to CEREC. CEREC requires you to use CEREC effectively, even today, as good as it is today, okay? You have to develop a new skill set, and you have to be a better dentist. It doesn't compensate for bad dentistry, okay? What it requires is you to do your job perfectly, which is a little bit different. There's obviously similarities between analog and digital, but there's differences too, that you have to understand the differences and how to develop the workflow to optimize those differences so you get the results that you've been getting. So that's fascinating. You did 30 some odd thousand restorations. Have you published on any of those, or I'm sure you followed quite a bit of those? What have you found? Hopefully we do have some CEREC dentists, or certainly people that are considering it, because more and more people. What would be a couple of pearls maybe that you would say that were critical in your ability to be very successful with it?
It's interesting that, let's say, the first generation of ceramics, the feldspathic ceramic, still performs, I would say, the best.
Yeah.
The best if we look at all the aspects. So longevity, nice looking, nice optical integration. So for example, 12 years ago, I started also using Enamic, this hybrid material, easier to mill, easier to work with the machine. You can use it in thinner dimensions. So I introduced this material as an add-on, as an addition to my portfolio, because most of the restorations, or let's say CEREC dentistry, is re-dentistry.
Right, okay.
We're not, if you have a tooth with a cavity, at least in Switzerland, 95% of the cases you do just a direct composite filling.
Composite, yeah.
You don't do CEREC inlays, onlays, crowns, or veneers as a primary intervention. You do it to replace amalgam fillings in insufficient larger restorations. So the concept, the CEREC concept that I did that is volume based. The smaller the volume, the more likely you use composite. The larger the volume, the more you get advantages of using indirect or semi-indirect methods, where you avoid shrinkage, where you avoid a lot of shortcomings composite, even modern composites still have. So this is a combination of thinking about or knowing the materials you use. So this is also a message. Don't think the best material is the latest material or whatever. So we all know, for me, still, let's say, although it's a dying race, doing hand layer, feldspathic, platinum foil veneers, or whatever.
But they still look great.
Yeah, they look great. But the main message is learn to and know the materials you use. It's the same with technology. Go to the basics. You should know how the basic materials you are using perform, work. And if you know that, it's much easiher, much less stressful.
And so we could make love for you to make a couple general recommendations, since you've done over 30,000 restorations, excuse me. And I'm going to come back to that feldspathic in just a second. Maybe the audience doesn't quite understand that. But where would you use Enamic today versus like a Vita block or an Empress cat, which is it's just a feldspathic block? In fact, let me just deal with that. For the audience out there, I think everybody on dental earth has heard of lithium disilicate, specifically Emax, okay? A very high-strength glass ceramic. The original glass ceramics were actually blocks based on a feldspathic-type glass with some lucite crystals, kind of like porcelain, but in a block. And those are beautiful, and they're still working well today. And I couldn't agree with you more. If it's done correctly, bonded correctly, designed correctly, control the occlusion, I don't see really any necessarily clinical difference fracture-wise. But aesthetics-wise, they do have a definite improvement because the optics are very similar to enamel. So couldn't agree with you more on that. But share with where you might choose one or the other type of material.
Oh, Enamic, and the rays of Enamic is also related to the rays of more abrasion cases, erosion cases coming that just, they always have been there, but the number has increased dramatically over the last decades. And
that's where you'd use it. You'd use it more. You'd use it more in wear cases. Okay.
Yes. No, because I always tell people, they're arguing, oh, this material abrades much faster, blah, blah, and so on. Yes, that might be. But abrasion of material is a very complex thing that it cannot just be measured in a chewing simulator. The human body, you can do the same restoration in 10 different patients, and you will see different patterns, how they abrade, erode, because it's not only the pure force strength data. It's like somebody told me the ideal patient is a female Japanese. If you put the restoration in a female Japanese, she doesn't chew very hard. She's a very tiny, very let's say slim person with less bite forces, so the materials will last much longer in this person than in another person. But coming back to this, I always tell people, how do you treat a bruxer? You give him something that is not too hard. We are working with splints made of composite
plastic, basically.
Plastic. Okay. So think about replacing the splint with your restorations.
Right. Okay.
In the beginning, now it's a little bit better, but in the beginning, when I switched from feldspathic to Enamic in certain cases, the patients realized the difference in biting on it. They were like telling me, "Oh, doctor, this feels softer."
Yeah.
You know?
Well, let me. That makes great sense to me. Maybe you're motivating me to try it a little bit more. We're later on today, Miguel Ortiz is going to be on, and we are going to talk about that. He loves Enamic, by the way. Where have you seen problems with it then? Have you seen excessive wear? If you're putting in bruxer cases, that would obviously be one thing you would be looking for. Have you seen problems with that, or problems with maintaining polish? Has that been an issue?
Well, the Enamic, and Miguel will also talk about that. The major thing is you have to treat it right in the beginning. From the beginning, you have to polish it more accurately. Treat it like an extra special composite. And composite materials over time have shown that they are resistant. They lose their glossy shine over time, but the patients always have saliva on the tooth surface. They're not walking around and drying their tooth surface to show you, look, doctor, this surface is not shining anymore. But that's a fact. You can repolish them if needed. It's interesting that also there we see differences in patients. Some patients are really polishing their Enamics and composites, just how they brush and clean their teeth. Others show more roughness because they are maybe more on an acidic diet or whatever. That has an impact also on these materials. But overall, I think if you make a good case selection, a good planning, establish a well-balanced occlusion, avoid premature contact. So the concept for me was from the beginning with CEREC was working on not always a pure canine guidance, but a group guidance. That I try to distribute the forces to as many teeth as possible.
Right. Okay. Great. So one of the things that you were mentioning when you were going down the list of materials, so that sounds like a great option, especially if you have, you're restoring occlusal surfaces, but you're trying not to build it up too much. You have minimal space, and you're maintaining the vertical at about the same level, but filling in the spaces there of wear. When would you maybe switch that thought process to restoring with lithium disilicate or potentially a feldspathic type material? I just tell you my thought quickly. I mean, if I'm opening the bite or restoring vertical, depending on how we want to define that, maybe a millimeter and a half on each tooth, then I'm going to do something like Emax, and I've actually been fairly successful with that, not seeing particular issues. with fracture or anything like that, if it was Emax against Emax, let's say?
Well, basically, I left a little bit Emax because I don't like the extra step of putting it in the furnace.
Oh, okay. All right.
So, and then for me, the result, even using feldspathic, if you bond it correctly, if you have a uniform shell bonded on a tooth, then it's not an issue. The problem arises if you have irregular preparations with differences in dimensions of the restoration over the tooth surface.
Right.
But if you have like a shell, so the discussion or the thing is, you can use like immediate dentin sealing, you can seal defects on a tooth surface in order to create at the end a let's say almost uniform shell covering the tooth surface.
Right.
And if you have a uniform shell that is 1 millimeter, 1.2, 1.5 millimeter uniformly around the crown and bond it on this surface, and it's
I mean, even if we look at Pascal's work over the years, where he did onlays out of layered feldspathic porcelain, which is the weakest material out there, and I think he reported on 50 or 60 over the years for several years, and really only one of them fractured, and he was able to rebond the pieces, as I remember. So that tells you even very, very weak materials bonded correctly do phenomenal over time. So if we have better, more resistant materials to fracture, or better wear resistance or a little bit of flexibility in the material, they should do great bonded well. And that's a good message to get out there to people. Great.
I think the bonding is the most important part in what we are doing. And you as a lab technician, layering feldspathic ceramic on PFM crowns, that's a very weak material, but bonded properly on the metal substrate, on the gold substrate, works.
Yeah, it's what I know you knew John McLean, very famous dentist that knew Peter Scherer very well. I mean, the icons that we all learn from, right? That most of their stuff is still relevant today. He talked about a concept called a constant strain system, and meaning when you layer two structures together and they're bonded very well, the stress distribution is significantly better, number one, okay? It's not just holding the restoration on, it's spreading stress from occlusion, basically. And that if you have a stiffer substrate, for instance, enamel and or metal and or whatever, that it's bonded to, it's much significantly harder to start a fracture if you have good bonding because of the stress distribution. So I can tell you my experience. I haven't done 35,000 restorations. I've done 3,000 or 4,000 Empress over the years, Emax over the years. We can lump all these together, and I can tell you that the failure rate is where I didn't bond well. I can just tell you that, and it wasn't high. I mean, I didn't have excessive bond, but I maybe cut a corner. I used an all-in-one adhesive. I believed what the manufacturer told me, that I could use a resin reinforced glass ionomer, and they just don't work well. You have to seal the dentin well. You have to attach well to the dentin and the restoration. So share with you another interesting thing on the other side of this. I don't know where are you at with zirconia today, but we're gonna be publishing some very interesting stuff pretty soon. We'll be talking about it in the rest of the show later. I honestly don't believe you can, with what we're doing today, can get a very effective bond to zirconia. I think we can get reasonable bond strength, but the most I got, I tested 5 or 6 different bonding agents, and I'll tell you a fun thing that I did was I wanted to know how much the pure bond strength was just from the MDP primer, because we're told how wonderful the MDP primer, the methoxy or whatever 10 long word. I got some zirconia specimens. I polished them. I cleaned them so they were perfect. Okay, I cleaned them with everything you could imagine. I used 4 different zirconia bonding agents. Okay, Z Prime Plus, Monobond Plus, Curari's Ceramic Primer Plus, and Scotch Bond Universal Plus. Guess what the average bond strength I got on all 4 of them? It was under 5 megapascals.
For me, zirconia let's say where bonding is not perfect, zirconia is used as a replacement for larger restoration.
Yeah. A bridge.
From my point of view, and it doesn't make sense to do zirconia veneers. A lot of things don't make sense because we have material that perform better
and
like industry looking for the one material that does it all. And the one material that does it all does not exist. So basically, depending on the indication, there's a niche for zirconia, for the bridges, put it on implants. There are some indications where zirconia is my choice or should be the choice, or at least something you have to think about. And in other indications, go for feldspathic or go for Enamic, go for lithium disilicate, or go just for composite. That there's not the magic material, the magic tool does not exist. And this gets me back to the point that you should study, that you should learn and know what material performs in what situations. It's like, I know some dentists, if the patient asks, "Doctor, you just cemented a crown. What material is this?" And the answer is, I have to ask my lab technician. You know what I mean?
Yeah, they don't even know what they use.
It's a ceramic crown. It's a ceramic crown.
Right.
What ceramic? You know what I mean? So this is the thing. This is the thing that
Yeah.
I have just my dog entered. We have a nice pug lady.
Well, I'll interject while you're saying that then. So basically, what he's saying, and I agree with it.
Sissy. This is Sissy.
Okay,
Sissy.
great. All right. So are you in the office or are you at home today?
I'm in the office because in the morning I bring our dog. During the week, she's like in a kindergarten for dogs.
Right. Okay. All right.
Playing with other dogs and.
So we'll summarize with that and move on to another topic. What I think you're saying and what I would agree with is that you basically don't adapt the clinical situation to the material. Whatever clinical situation is present, you look for the optimal restorative solution for that clinical situation, and too often we don't do that. So anyway, now tell me how you got involved in, and you've been a professor at the University of Zurich. You still teach there. You were editor of the Journal of Aesthetic and Restorative Dentistry. Wow, I mean, when do you sleep? So how did
basically
you get
a lot of people are asking me about my time management, and I think time management is the most critical thing in your whole life.
Yeah, well,
so I have a very tight schedule, so I'm although being an Italian.
Yeah.
I'm maybe this is the German part. So my father's from Italy, my mother's from Germany, and I have taken some German things to be on time to try, and also the Swiss part. Like my mission statement is Swiss quality with Italian style.
Yeah. I gotta say, if I was going to live in a second country, it would be Italy. I just love Italy. There's just something that appeals to me, and I've taken some art classes there. To be respective of your time, we'll go with like 3, 4, 5 more minutes because I told you we'd keep it at 30 minutes, and it sounds like we're going to need to because you probably got something else scheduled in the next 5 minutes. So you were a professor at a university, you taught a whole bunch, and then you decided to move a little bit back more in the private space teaching, and you started this dental TV company. And make sure you get us that link because I want people to check that out, please. Honestly, I'm not fluffing this. He is the best. Alessandro is really your best resource for photography today, not just in learning how to do stuff, but also to learn about the equipment. And this stuff isn't cheap. We all know that. Okay, every time we're turning around, it's a $3,000, $4,000 camera, $2,000 lens, and how to use these programs. And he has all of that information. And he's got a website that you sign up for and courses you can sign up for, and they're not expensive. They're very, very fairly priced to cover the cost of basically his team. So when did you start that, by the way? So maybe we'll finish up with that. Share a couple of ideas.
I started dental TV 2 years ago. So the idea was there are many dental education platforms out on the market. So it was not about doing another one or copying other ones. What I saw is that if you browse all these dental education platforms, you see the same content all over the place. Basically, almost the same teachers, the same webinars, the same projects. At the end of most of the webinars, you got the information. Hi, I'm at McLaren, and if you want to learn the details, I have a private education center in California. Come and join me for my 3 weeks education workshop that is only $50,000. And at the end, you could have told me this in the beginning, that you want to sell me your workshop. But I'm not angry with all these guys, because if you are asked to be on all these platforms and present your knowledge or share your knowledge, what do you get? So basically, I'm not doing this. I was like saying, there are so many things that not only the younger generation, but especially the younger generation do not learn at dental school.
Yeah, that's
it's
getting
photography,
worse.
it's videography, it's social media, it's marketing, it's well-being, it's how to lead a team, how to train yourself, how to eat healthy. It's huge. And basically, I'm trying to just answer questions. So now I have 350 videos on Dental TV, and it's growing. Because every time I hear a question from someone on my Instagram, on other platforms, I try to record the answer of this and post it then on Dental TV. So this is how the thing is growing. And I'm inviting people like you or anyone out there, instead of starting your YouTube channel, join Dental TV, and we publish, or I create a series with all your YouTube videos. And it's like the idea, the concept is, together we are stronger. Basically, the issue I see in the dental community is that we have too many solo creators, solo entrepreneurs, and we are missing really out the community. Even if you think about all the academies around the globe, go to the American Academy, European Academy, whatever academy. You go there, you clap on each other's shoulders and saying, wow, Ed, you're such a cool guy. And you say, hey, Alessandro, you're even cooler. And then we leave. Monday morning, you're back in your office. I'm Monday morning back in my office. And somebody's asking, by the way, was Ed on the meeting? And I was like, who's Ed? So basically, we meet each other, we have fun, we drink a beer, we enjoy the time, but for me, it's not like really friendship. Maybe there are some friendships going out of these things. Don't get me wrong. But basically, you go there, you cheer up, and then you go back to your dental office. And this is what the majority is doing. So I always tell people, wake up, look what's happening around, what's happening outside your dental office. Enjoy your life. And then we don't need all these people that are now lecturing about mental health, about suicide of dentists and whatever. I can't hear that. If you are passionate about something, I'm sure you can overcome all these problems that are around, not only in dentistry. So basically, but the major issue I see is that the dentist tends to close himself or herself in this cage called dental office, and is not looking outside. And if you not look outside, you don't improve yourself, you don't communicate, you don't learn. And then if you stay there and at the level of your graduation 20 years later, you find yourself in a deep depression for sure.
Right. And that's a great point. I mean, what I like to tell young people, I've graduated hundreds of students like you have over the years, is, the reasons for meetings is really for the friendship, for the fellowship, okay? And maybe to open up a new idea, to open your mind to some new concept, okay? But then you need to, now, because the world's evolving with education and how we disseminate information, this is a great avenue, learning from somebody like you, or learning from your platform. Because yes, it is a multidisciplinary platform, bringing lots of people together like me, and I'm going to do some content for you like we talked about. And then the other thing to remember for the audience out there is that all of us lecturers, okay, especially if we're invited to the big meeting, okay, we're showing our best cases. We're showing dental Disneyland, okay? Or, excuse my French, dental masturbation, okay? That is great stuff, but we don't get that all the time. We do our best to get that. So don't get depressed by that. That drives us to a little bit better in one case, a little bit better photograph. You know, they've asked, on touching on photograph, they asked some great photographer, I don't know if it was Ansel Adams or somebody like that, why his photographs are so good. He says, there's not. I just take 3,000 a day, and 1 or 2 of them come out pretty good. There's a good message in that you have to do a lot of practice to end up with the one good restoration, the one good photograph. All right, buddy. So maybe we'll wrap with that. Anything else that you'd like to add? Because we're a little bit over that 30 minutes I promised you. But that was great information. And one thing I'd like to ask is, what's going try to keep this short. What's going on in Europe today? What do you see different about Europe and maybe the rest of the world, and maybe specifically Switzerland and stuff like that? Dentistry,
what we see in Europe is a decrease in income of the dental community, and this is also a factor that helps to create more depression. So we have a shift from a male profession to a female profession.
Okay.
Nothing against female dentists, don't get me wrong, but the female dentist has a less working hours, because if a woman then decides to have also family, she's not able to work 100%. So there's a huge shift in dentistry that is very rapidly coming.
Yeah.
And we need to be aware of that.
Yeah.
And many things will change automatically. You know, the conferences will change, academies will change, everything will change, because the work-life balance looked from a female dentist is not, I want to have more fun. I want to have more time for my family. If you decide to have a family, and this is then the work, it's not work-life, it's work-family.
Right, exactly.
Thing, you know, and this makes a change. So my wife was staying at home with our 2 kids, and I was able to work as long as I wanted, as hard as I wanted. She supported me. She still supports me. Now our kids are adult. We have even a grandchild, but you know, it's 5 years old now. But you know, this is the thing. So that's a culture, that's a change in our society that we need to be aware of and face it.
On maybe a dental school perspective on that question, do you see, here's what we've seen in the United States, and just see, is what's happened in the United States is they've had to charge patients too much, I believe, for dentistry, okay? Because the schools making up deficiencies in income, that as the schools, I still teach quite a bit in schools, not full-time, but you know, courses here, there. I'm seeing kids graduate from school doing 5 restorations total. That's it. And, you know, a busy dentist will do 5 in a day. Some people we know will do 20 or 30 in a day, right? And to me, I mean, they're just not getting the experience to be competent. And when they graduate,
the level of education has also dropped. The level of practical manual education has dropped also in Europe because of some reforms that we had to increase the theoretical part of our education. But this then is the message to the young generation, or to the young doctors out there. If you have graduated, I would say education starts right away.
Absolutely.
If you go out of dental school, then your practical education starts. And that's, again, where Dental TV can help with the non-dental parts that are also having a huge impact and a growing impact on the overall, let's say, quality of life, quality of work, personal development. So these are the things. Don't stop. Don't think if you have this master degree in your hand that you are finished with your education.
Right.
It just started. It just started that day you went out of dental school. Your education just started.
And I can tell you, having done this almost 40 years now, and you have probably getting close to that too, I can tell you, you just see that. the young people that come out of school that start learning from people like you and start getting involved with study clubs and start, trying to find a way to incorporate a reasonable level of continuing education end up doing better financially. It's not just the cost of doing it, it's also the reward of doing it. All right, buddy. Well, I'll let you wrap up with any last couple of things you want to share with the audience.
Okay. My last words are the words that I always see in all the interviews I have done during the pandemic. Be passionate about what you're doing, love what you're doing, and never stop learning, never start being curious. Let's say, as a man have an advantage over women. Men never get adult.
That's true.
Men always keep being a child. So we hear that from our wives that you're still like a child. But
okay, that's the same everywhere in the world.
But be curious like a child, and keep that. That many of us are losing this attitude, this thing of being curious, trying to learn, trying to explore. Keep that, and I'm sure your life will be much better.
Okay, that's a great way to finish. And I would like to thank Dr. Devigus coming to us today from Zurich, Switzerland. And that was beautiful. And thank you, everybody. And thanks for turning into this episode. By the way, we'll get you a copy of this. So if you want to post it on your social media, and also please send us a couple of links so we can put in the show notes. Okay?
Cool.
All right. Signing off,
Take
everybody.
care and talk to you soon.
Thank you.